Dear Faye, we're on streaming.
Hello, everybody, and welcome to our second webinar out of our 5 international webinar series. Thank you ever so much for taking the time to be here today. I'm really excited to introduce you all to our second webinar, which is entitled Person-Centered Challenges and Solutions to the Management of Long-Term Conditions. And this is in Chile and in the UK. So just bear with me one second. So this webinar is basically an amalgamation between 3 different institutions, and that's Teesside University in the UK, the Universidad del Desarrollo in Chile, and Pontificia Universidad Católica de Chile as well. So it's great to be here. And first of all, what I'm going to do is just basically explain our aims of this webinar. Essentially, that is to share evidence-based knowledge exchange between our universities internationally around the globe. So first of all, I would like to welcome our first university, which is the Universidad del Desarrollo. So Baltica, can I please ask you to introduce your institution?
Thank you, Faye, and good morning, good afternoon to everyone who's seeing this through the streaming or the Zoom seminar link. My name is Baltica. I'm a social epidemiologist and director of the Center of Global Intercultural Health at Universidad del Desarrollo in Santiago, Chile. This is a private university that aims to develop innovation and knowledge through undergraduate and graduate training and research. I'm very pleased to be a part of this cooperation along with Pontificia Universidad Católica de Chile and Teesside University. At Universidad del Desarrollo, we're extremely happy to be promoting these opportunities to share knowledge and catalyze research across the globe. Thank you very much, Faye.
Thank you so much, Baltica. I'm now going to introduce you to our second institution, which is the and excuse me if I say this incorrectly, Pontificia Universidad Católica de Chile. And we have Manuel Espinosa. So welcome, Manuel.
Hello, Faye. Hello, colleagues. Thank you very much for this opportunity. It's good to see you all again in this second webinar. I'm Manuel Espinosa. I'm Associate Professor at the Faculty of Medicine of our university. Our university is one of the oldest universities in Chile. Not the oldest, but one of the oldest. And it's a Catholic university because at that point the country was very Catholic, but it's like more traditional university, we call it here. I'm very proud of being part of this collaboration alongside Teesside University and my colleagues from Universidad del Desarrollo in Chile. The focus of our research, I lead the team of a health technology assessment unit at the university, at the faculty, and I'm also principal investigator of the Center for Cancer Prevention and Control in Chile, which is based in the university, but also includes collaboration with other universities here in the country, University of Chile and Universidad del Desarrollo, among others. So I'm very happy to participate today and the topic that we're going to discuss and to share some thoughts and knowledge with our colleagues. Thank you very much.
Thank you, Manuel. So I am an academic here at Teesside University, and I actually have a background in chiropractic and public health, which would be Salud Pública in Spanish. So our webinars largely centre on the topic of public health, and that's basically the theme running throughout the next 5 months. Our webinars essentially are running on every Monday, the first Monday of each month, more or less. Sometimes there's a slight difference in those dates, but more or less the first Monday. And essentially today, we're going to be looking at chronic conditions, which are really important. Across the globe, they account for a large proportion of our healthcare expense, roughly 75% in developed countries, and they also account for roughly 50% of GP visits. So it's a really important topic. And to open that, I would like to introduce you all to my colleague, Professor John Young. So John Young, we're very lucky to have him here today. He's the director of the Centre of Biodiversity here at Teesside University, and he's a professor in translational healthcare. He specialises in the diagnostics and therapeutics of patients living with chronic conditions, in addition to patient education. He completed his PhD at the University of Cambridge in the United Kingdom, and he was recently commissioned by Health Education England to produce CPD for NHS England employees regarding continence management in adults and frailty. And probably most importantly, he actually was the reason why Teesside University had a visit by our current Prime Minister, Rishi Sunak, back in January, February of this year, regarding the research that he conducts. So I will pass you all over to John. Thank you, John.
Thank you, Faye, for that very kind, very generous introduction. I'm just sharing my screen with you now. And Faye, if you'd be so kind as to confirm that you can see the slides, please.
I can, John. Thank you.
That's great. Fantastic. Thank you. Thanks very much to the organisers for this. I won't list them all by name because we have a limited amount of time, but I'm very grateful to them for their efforts. So thank you for the opportunity to speak. I'm going to talk about person-centred solutions to the management of long-term conditions. And there's my contact details, my email address in the bottom left-hand corner there. Now, why is it not there? So firstly, just brief conflicts of interest. I think it's very important to do this. So I have undertaken contract research for a number of large pharmaceutical companies that I list and that top bullet point. I've collaborated with Pfizer on an EU-funded FP7 grant, details of which are given at the very bottom of the screen. I undertake consultancy for a couple of organisations, Tenor and Essity. I've had funding for a research conference from another large pharmaceutical company, and I'm the co-founder and chief scientific officer for a company that specialises in diagnostic testing. So there are some conflicts, and I think that even though I don't want them to, they're likely to have some subconscious influence on what I present today. And I'd like you to view the slides with that lens in mind. Now, what I wanted to do was to refresh my own understanding of the term person-centered, because it's a phrase that is very fashionable. It's a phrase that we use very frequently. And I think we can use that phrase in a quite a confrontational way to define person-centered as the opposite of service-centered. So instead of focusing on the needs of an organization or a community by having care delivered in service hubs, we instead try to focus on what's important for the individual. So that's a good definition, but it perhaps is a little bit negative towards the needs of the community. And I think actually there are some better definitions, and a good one comes from an article which is just over 5 years old, published in the British Medical Journal by Berger et al. And there are 5 key points to their analysis. So the first is that person-centered should be focused on the relationships that are important. So, for example, we need to understand that when we're dealing with diagnosis, there's an element of trust that we need to have with the patient and sometimes with other healthcare practitioners within the large multidisciplinary team that care for that individual. Building on from that, we need to understand the roles and responsibilities of all of those individuals. And this extends to family members and to carers as well. And finally, and quite significantly, we need to understand that in the way that we communicate and the way we handle diagnosis, we need to ensure that the dignity of the patient is at the heart of what we do. A second point to Berger et al.'s analysis is about the exchange of information. So we need to understand the medical and informational needs of the patient. What do they need to know? What do they want to know? And we focus on that rather than anything that we think that they might need to know. A point that comes up a lot in social media in terms of patient-centered care is the respect of a patient's knowledge. So a patient with a long-term condition will often have done lots of research around a subject. They'll have lived with that condition for many, many years, and they may know a lot more about that condition than some of the practitioners that they will come across. And they certainly would feel that that's the case, and we need to respect that. I think that's important. And then the final point here is that when we share information with a patient, we need to do so in a manner that's accessible to and understandable by the patient themselves. So this is not an opportunity to blind a patient with science. We need to focus on the key bits of information and make sure that they're understandable and accessible. The third of 5 points is that we need to recognize, legitimate, and validate the expressed emotions of that patient. So if they have fear, if they have concerns about diagnosis, we need to make sure that the way in which diagnosis is conducted is sensitive to those needs, the feelings and emotions of the patient and of their caring group. The fourth point is there needs to be shared decision-making. It can't simply be the case that diagnosis is a one-stop shop, a one-size-fits-all. We need to respect all the different factors that go into making an informed decision. So we need to respect the patient's needs, values, and preferences regarding their care, including the desired degree of involvement in decision-making. Some patients will want to leave the decision-making entirely to healthcare practitioners. Others would want to be in the driving seat, and they want the guidance of their clinical team, essentially like somebody reading a map and directing the patient where to go. And finally, we need to do everything we can to encourage patient empowerment and self-management where it's appropriate to do so. So we need to enable the patient to make decisions. We need to provide guidance, skills, and access to relevant health and social care support services. We need to advocate for and assist patients in navigating the healthcare systems, which within the UK can often be quite complex. So these are the 5 pillars or axes by which I have gone on to then view the rest of the presentation. This is a very text-heavy slide for which I apologize, but I think it's useful to set the scene for the rest of the webinar series with this in mind. So apologies for the text-heavy nature. So I'd now like to pivot and move on to a disease that is important to me, which is overactive bladder. And this is a disease defined by urinary symptoms, which are increased voiding, increased frequency of voiding during the day and the night. Urinary urgency, which is the need to void the contents of the bladder urgently without any pause or hesitation, to go directly to the toilet. And then in some individuals, they will develop urinary incontinence, particularly as the disease progresses. Overactive bladder is a very prevalent condition affecting at least 1 in 5 adults. Recent epidemiological studies suggest as much as 1 in 3. There's an increased prevalence with increasing age, and it impacts all aspects of a patient's life and on the lives of carers. It really is quite a serious condition. Now, diagnosis is very challenging, and I apologize for quite an anatomical image in the bottom right-hand corner. That's an important reference point, though. So this is a complex diagram, and I'll just explain what it's showing. It's showing that in order to make an assessment as to whether an individual has overactive bladder, the pressure of their bladder is measured through this red and blue line that go into the bladder through the urethra, in this case from a male patient through the urethra of the penis. And this goes to a pressure transducer. There's a second pressure transducer that's inserted into the rectum, in this case of a male, or into the vagina if the patient were a female. And the aim is to measure the pressures of the bladder as the bladder expands with urine. In this case, it's not expanding with urine, it's being filled with a saline, a salt solution. And the clinician is looking for involuntary contractions of the bladder as it fills. So the bladder should naturally expand to accommodate urine, but in the case of a particular hallmark for overactive bladder called detrusor overactivity, the detrusor muscle of the bladder, instead of expanding to accommodate urine, will contract periodically. And some clinicians believe that this is a hallmark of overactive bladder, and as a result, this particular test is the gold standard for the diagnosis of overactive bladder. The problem with this test, as is very evident from the picture, is this is a highly invasive technique. But key is that it's also insensitive. It does not, unfortunately, provide good accuracy. And there's some references below that detail that. It's expensive, so it costs at least £1,200 in the UK because it takes place in specialist urology departments and requires a multidisciplinary team to undertake this method, and it's not suitable for adults with frailty. So thinking about how we might produce a patient-centered diagnosis, back in 2017, myself and a former postdoc, an amazing scientist called Dr. Sepinoud Faruzmand, who's now working in Australia, began a series of projects together where we aimed to improve diagnosis of overactive bladder. But the first question we asked is there a need to do so? So Sepinoud led a project funded, as you can see in the bottom right-hand corner, having 123 conversations with the different stakeholders, the different people for whom overactive bladder matters. So obviously that includes patients and carers, healthcare practitioners, but also other professionals in the care pathway for overactive bladder patients, and they're listed on this slide. And asking the question, how can we improve diagnosis? There were 5 themes that were identified. So the first is that the care needs to move away from a specialist referral centre in a hospital to the point of care setting. So that's a GP surgery, a pharmacy, or a care home. Secondly, the technique needs to be accurate. So it needs to differentiate the underlying cause of someone's symptoms from other similarly presenting conditions and diseases, things like a urinary tract infection, urological cancers, interstitial cystitis, type 2 diabetes mellitus, etc., etc. The third is that diagnosis needs to be non-invasive, so it's suitable for all patients, including adults with frailty. Fourth, we need to have a rapid outcome. So there's a single appointment where there is diagnosis and an assessment, and then a prescription can be given with no need to send the sample away, where it can be lost, it can be degraded, and where there's a delay on the outcome of that diagnosis. And finally, the test needs to be simple to use and interpret with no specialist training or equipment required. So these were the 5 pillars that were identified by thematic analysis of 123 interviews of different stakeholders. So fast forward 6 years, what we've been doing is we've been progressing along the spectrum of discovery, development, evaluation, and implementation to hopefully generate some of the impact that will come from better diagnosing overactive bladder using a patient-centric model of care. And throughout all of this, we've engaged stakeholders to ensure that what we've delivered is, we think, optimal. So there's a lot of information in the bottom half of the slide, and I'll take you through that. So our hypothesis is that there's chemicals within a urine sample that we can use to detect overactive bladder. And we measured many tens of different putative chemicals. And here's a graph which shows the total urinary symptom score, which is a clinical measure by which healthcare practitioners assess the severity of overactive bladder. So on the y-axis, worsening overactive bladder is towards the top, and no overactive bladder is towards the bottom. And then on the x-axis, from left to right, we see an increasing concentration of a chemical found within urine. And we've done this for many chemicals, and we find that when we combine them, we can get really good diagnostic accuracy, particularly for early stage overactive bladder. Because what's driving this is a desire to spot overactive bladder, not when a patient starts to suffer with symptoms, but at the point actually when they may not even be aware that they have overactive bladder. Because there's lots of evidence that if we treat early, we can treat effectively. If we treat late, then unfortunately the bladder has become remodeled and there's only limited efficacy of the available treatments. So using this, we're now in the process of developing a pregnancy-style test for overactive bladder. And I want to pause just to acknowledge the significant funding we've had from a number of organizations throughout this journey. And so I could stop there, and Faye was really kind to say that we've had a lot of interest in our work, including from the current Prime Minister, Rishi Sunak, for which we're very grateful. But it would be wrong to say that that test that we're designing is going to be successful, because context is really important. And we learn lots of lessons from understanding the diagnosis and self-management of other conditions. A great example of that is type 2 diabetes mellitus, which can be diagnosed and certainly managed using a blood prick, where the concentration of glucose within the blood is assessed using a device like the one we see in the top left-hand corner. Likewise, there's a device that's popular in the UK. It may have made its way to South America, and it's a wearable patch, and it again measures blood glucose, and the concentration is sent via Bluetooth to an app that we can interface with on a phone. And so you can see the patch worn by this individual helping herself to some salad in that photograph. Now, what's important about type 2 diabetes and other long-term conditions is about the context for diagnosis and self-management, that developing a device is not the end, it's actually just the beginning. And for it to be successful, there's an awful lot that needs to be in place. Now, mindful of the time. So the first thing is that we need to manage, we need to educate patients, carers, and healthcare practitioners about the value of self-management in a long-term condition. The second thing is that we need patients and any support network, including family members and carers, to change their behavior. So firstly, to incorporate self-monitoring as part of their daily lives, but they are typically required to do some other things as well, which in the case of diabetes management includes modifying their diet, quitting smoking, and typically increasing their physical activity. So a patient and their carers, family and that sort of thing, they need to have knowledge of the value of these interventions. But we also, as scientists, clinicians, we need to be aware of the psychosocial mediators of these behavior changes, that beliefs, attitudes, and coping skills will all affect the degree to which an individual can incorporate a new intervention in their lives, and to do that as part of other changes that are needed. And it's only then that we see the short-term benefits to these types of interventions, and then the long-term outcomes, reducing morbidity and mortality and improving quality of life. So to wrap up this short presentation, the key thing is to ensure that any intervention is person-centered, and we need to do that not as a late stage when we've developed a device, but to do that when we're conceiving, when we're having the idea of a device. The second point I've hoped to have made is that person-centered development of a diagnostic test for overactive bladder is exciting, yes, but there's a context that's important. So that leads into the third point, that we must now, so me leading this work and others developing devices, need to spend at least as much time characterizing the context of diagnosis and management of that condition as they do in developing devices. So thank you very much for your attention. I hope that's of interest. If you have any questions, my email address is j.young@tees.ac.uk. Thank you.
Thank you ever so much, John. That was fascinating. And I think, you know, the importance of having this webinar is to catalyze the impact of research that we're all doing. And the fact that you've taken research and streamlined a process that was before very uncomfortable and costly and invasive and intrusive, just summarizes the importance of why we are sharing this knowledge, and it's fascinating. So thank you ever so much for sharing that with us, and there will definitely be some questions at the end for you for sure. Thank you. Next, I would like to introduce Professor Manuel Espinosa, who will be talking about including cancer in a new model for primary care in Chile. Professor Espinosa, Manuel, is an academic, obviously, at PUC University within the Department of Public Health. He's also the head of the Health Technology Assessment Unit of Clinical Research Centre. He's a physician by background, although he has a master's in epidemiology, a master's in biostatistics, and also health economics. And that is also what he did his PhD in. So Manuel, I'd love to introduce you to present. Thank you.
Thank you very much, Faye. It's a pleasure again to share this work that we've been doing in the last few years. And I'm gonna start sharing my presentation. Can you just confirm that you are watching the right presentation?
Yes, we are.
Great.
Yeah.
So I'm going to share some the results of an experience we've had implementing a new model of care in primary care in Chile. It's called the multimorbidity person-centered care model. And I'm gonna end up this presentation with some ideas, introducing the idea that cancer in particular hasn't been incorporated formally in this model, and it's a challenge that we might want to address in the near future. I'm talking here on behalf of the unit that I lead, the Health Technology Assessment Unit, but also as in my role as a principal investigator of the Center for Cancer Control and Prevention in Chile, which is one of the largest grants that we can get in Chile. The grant was is a grant funded by the government in Chile, and the idea of this is that there is a center. We're going to have a center that is going to provide the evidence and the new ideas to implement what in Chile we call the national law for cancer. So we are starting this center. It's really important for us, and across a large collaboration of universities in the country and also abroad. So I'm going to put this experience in the context of the challenges we've got in the Center for Cancer. So basically, why to address the problem of multimorbidity, and let me show you just a very quick snapshot of the situation we live in our country with chronic diseases, also called non-communicable diseases. So Chile is a country of 19 million people, approximately, where 11 million adults have non-communicable diseases, at least one. And 9 million adults have reported multimorbidity, according to our national survey of health. Unfortunately, the problem is that our primary care health system has limited capacity. So basically, our estimates says that our primary care system only can handle 4 million people per year. So that even duplicating our current capacity, we won't be able to attend all patients' needs at population level. So we need to think about a different way to provide primary care, generally speaking, to the population with these limited capacities. So around 5 years ago, our university started a collaboration with one of the biggest healthcare services in Chile. We call healthcare services here is an administrative unit similar to what you go in the UK, like the primary care trusts. But the health services here are not only in charge of primary and secondary care, but also hospitals. So basically, they are in charge of a whole geographic location in Chile with the population living in that geographical location. And they manage all the health facilities, including hospitals as well. So we implemented, in collaboration with this healthcare service and the university, a new model of care in primary care, but also interacting with the other levels of care, the secondary and the hospital level. So basically, instead of providing the previous model, which was based on a single diagnostic approach with fragmentation of care, where, for example, if the patient has diabetes, he or she is seen by a doctor that is going to be focused only on the diabetes problem. And if he or she also has hypertension or dyslipidemia, he's going to be seen in another consultancy and probably by another doctor. If he suffers also pains or mental health problems, so it's going to be seen in another consultation by another doctor. So now what we did is to change that model of care. Now the healthcare team turns to the patient and sees all her problems jointly. But because of the limited resources I was talking about, in particular in the primary care, so we needed to use the same resources to provide a different way of care. So for that, we categorized the patients in low risk, moderate risk, and high risk. And most of the resources are turned to the high risk patients. And low risk patients are, we promote self-care and other techniques to provide care to them, but not spending much of the primary care resources on them, but to the high-risk patients. So basically, the goal of this integrated approach is to avoid complications from multimorbidity and reduce health services utilization, avoiding duplication of care, and of course, indicating the most adequate service in a timely manner. So in order to do that, to meet that goal, the system needs to reorganize the capacities, focusing more on high-risk patients, as I said. So this is a snapshot of how the different activities, operational heights and roles of the healthcare professionals are now reorganized to attend the low complexity patients in green, the medium complexity in yellow, and the red, and the high risk patients in red. After 3 years of follow-up, we have produced some really important evidence about the impact of this model. In this slide, we see this significant impact in all these health system performance indicators that we're showing there in both tables. For example, number of hospital admissions, length of stay in hospital, number of consultancies to hospital emergency, and so forth. So basically, this impact was observed in both either high-risk population or the general population, the whole population, including low and medium risk. We found significant impacts in favor of the new model for all these performance indicators, but also in death, with very significant estimates on this. So we produced this evidence and we passed to the Ministry of Health, and the Ministry of Health is taking this experience and scaling it up to the rest of the country to 2023, actually. So we complemented this evaluation with a costing study, an economic evaluation. This was a project funded by the World Bank, which was really interested in the Chilean experience, and they asked us this economic evaluation as a mean to export, let's say, the experience, the Chilean experience, to other countries in the region. In particular, countries that are really interested in this mode of care are Uruguay, Brazil, and Colombia. What we're showing in this slide is the results of this economic evaluation of this new model compared to the more standard model of care that we got in the country. And we found a total cost reductions of 12% attributable to the intervention. So in overall, the new model produced a reduction in total cost by 12%. Now, this reduction, it is at the expense of the reduction in hospital cost mainly. If you go to the bottom line, you see that what we found is a 19% reduction in hospital costs during the time of follow-up. Interestingly, the other items, which is cost in primary care and secondary care, we found a significant increase, which is quite consistent with the type of model we were implementing, where we put more resources and more energy and more effort in the primary care in particular. And actually, as you can see, the increase in cost in primary care is around 32% increase in costs. And that is rational because we were spending more resources in primary care to make a better performance. The good thing is that by doing better by having a better performance in primary care, we are getting reductions in hospital. And because in hospital, the expenditure in hospital care is a lot higher than in primary care, that reduction, that 19% reduction, explains the total reduction in the whole population. So these are the results that we provide in a very simple way. This paper of the economic evaluation is under review. The other ones of impact are already published. And as I said, this complements the whole view of that putting the person at the center of care in a multimorbidity approach is the right way to move. And that's why our Ministry of Health is changing this gradually from this year onwards. But there are some things that are challenges, because we didn't include in this current model, for example, other areas like pain, chronic pain, which was the topic of our previous webinar, where we talked about how we are addressing that challenge. And now I would like to include the idea of, we haven't included in our model the cancer care. And we think that a national plan for cancer needs the primary care. And usually we think of cancer in a very specialized manner, basically in hospital care. So all the patients, all the problem of cancer is managed by hospitals or secondary care where specialists are. But we really believe that this needs to go to the primary care. And we need to implement some potential actions. And there are two extreme ideas here. First is in the area of prevention. Based on the experience we're having in the multimorbidity model at the primary care, we think that we need to improve secondary prevention as part of the multimorbidity model. So we know that high-risk patients with regular non-communicable diseases like hypertension, diabetes, and others are more likely to have cancer as well. So an emphasis on improving coverage in those patients in screening absolutely should be made. So we need to remember that the main risk factors of cancer include obesity, alcohol consumption, tobacco, many of which are common risk factors with most non-communicable diseases. So if we are managing high-risk patients with all this multimorbidity, we need to think that this patient must have a cancer in the following years. So we need to be very strict with the secondary prevention and the so, of course, we need to improve the time to diagnostics, but that is regardless the model of care that we're implementing is a challenge that we are addressing in the country anyway. But on the other extreme is that we need an effective counter-reference to primary care. So currently, as I said, most of the problem of cancer is being managed by specialists in the hospital level. But at some point, when the patients are in a particular stage of the diseases, in particular during the follow-up, probably patients can be counter-referenced to primary care. But of course, we need more training in primary care professionals to take proper care of this type of patients. But it's something that we need to implement nearly in the future, because we need to make possible that the time of our oncologists are going to be wisely used in those patients that really needs them. But there are other patients that can be absolutely managed in the primary care in a very good way. As long as we have a fluid communication between primary care and oncologists in the hospital level, I think that is absolutely possible. And it's something that we need to think, and probably is one of the ideas that I would like to throw to this panel, and how we can implement, and maybe to learn from the experience of our colleagues in the UK about this. I'm going to stop there. Thank you very much.
Thank you very much, Manuel. That was, again, really fascinating. And I think, both yours and John's presentations have just highlighted that, there is a need for a change in how, in basically healthcare systems and how those frameworks look and how they work most effectively. So thank you ever so much for sharing that with us. And again, like I said, there will definitely be questions at the end. So I have some in particular. So thank you ever so much. I would next like to introduce our final speaker for today, Baltika Kabiesis, and her speech is going to be on person-centered solutions in healthcare, valuing patient patient trajectories in cancer in Chile. Now, Baltica is a professor of social epidemiology. She's the director of the Center for Global Intercultural Health. She's also the national coordinator of the Chilean Network of Research on Health and Migration and a former co-leader of the Lancet Migration for Latin America group. So welcome, Baltica.
Thank you so much, Faye, and thank you to the two previous panelists for their brilliant presentations. Really, I've most enjoyed listening to them. I'm going to provide a complementary vision on what has been discussed so far, raising the voice of patients and organizations related to cancer in particular in Chile. So this presentation is entitled Person-Centered Solutions in Healthcare, Valuing Patients' Trajectories. It's also called Journeys, Pathways, and so on, in cancer in Chile. And I'm going to speak around the case of breast and pulmonary cancer based on a study we finished last year, which was a multi-methods research study in which we produced novel knowledge around the voice and experience and unsolved needs of patients going through a cancer diagnosis here in Chile. So I think that's also part of what patient-centered care is about, listening to people's experiences and voices and understanding their own visions around what they're going through from their own voice. That has a lot to do with both John and Manuel have already presented. So I'm speaking from the Center for Global Intercultural Health. We are a multidisciplinary research team created in cooperation across two different faculties, Medicine and Psychology at UDD. We care about creating state-of-the-art research on global intercultural health and its contribution to creating solutions for health systems and communities with a global South perspective. So I'm going to start from the point of patients' participation in health. It's quite often to find discussions and webinars and papers around health systems performance, governance, financing, and so on. And there is a need for perhaps balancing the value and the evidence around patients' participation through all of those processes. So in relation to this, patient participation is valued and desired in healthcare decision-making at every level. It could, and it has, based on existing evidence so far, promoted a more patient-centered, democratic, and legitimate processes for both individual patient decision-making process at the point of delivery in healthcare, but also at high-level health coverage decision-making for deciding what to cover, for whom and how. It also raises awareness of communities' needs, experiences, and perceived unfairness in their everyday relationship with their health systems. From a social determination of health and an implementation science perspectives, but patients' participation also brings richness and depth to technical evidence, as it often complements quantitative with qualitative knowledge through a mixed methods approach, and therefore producing novel, rich, dense evidence. It is also important to say that Chile has many hundreds of patient social organizations related to chronic conditions, including those who are living with cancer, with a diversity in size, motivations, goals, functioning, and expected outcomes. However, how organized patient views and everyday patients are incorporated into the decision-making process related to health coverage is not entirely structured as a process. It's not always transparent or systematized in a coherent way, and it usually lacks a consistent framework and guide in almost every country. So Manuel spoke a bit about Chile. Here's a few new additions to that. Chile is the southernmost country in the world and the closest to the Antarctica, occupying a long and narrow strip of land between the Andes, that are massive mountains, beautiful mountains, to the east and the Pacific Ocean to the west. Chile has been defined as one of the South America's most stable and prosperous nations in the past decades. And since July 2013, Chile is considered by the World Bank a high-income economy. In May 2010, Chile became the first South American country to join OECD. Cancer, now moving on to the topic of this presentation, cancer has been defined as a public health priority in Chile, as well as a global public health priority, supported by the cancer law and the National Plan of Cancer, which are fairly recent and still in development. However, the sole creation of this legal and normative instrument does not guarantee the following elements. First, equitable and timely access to healthcare services. Second, efficiency of the use of public resources. And third, improved population health outcomes and their equitable distribution across society and across communities. Here's an estimation of cancer based on estimates from 2018. We can see different regions in the world and how Chile compares to others. Following the recent cancer law and the National Plan for Cancer, it has been defined that the Chilean health system needs to produce robust evidence to create and promote feasible and sustainable health policies and actions to accomplish its own goals. And it is also challenged to incorporate relevant social dimensions in its decisional process. This is explicit in both documents, being the voice of patients and organized patients, one of the most significant ones. From that perspective, and with the idea of producing knowledge from robust research that synthesizes the voice of patients in cancer in Chile, we anchored study in the concept of patients' therapeutic trajectories, also called patient journeys and others. So we're hoping to give a voice to patients from understanding their involvement, how they could collaborate with the health system to promote their own health and others, but also how empowerment is produced. So there are different definitions around therapeutic trajectories, and we're using the one particularly for this presentation only. I have to constrain the presentation around a few ideas only, given time constraints. Focus on the right side, the health system approach. And that is the path a person follows within the health system in search of solutions to their own health problems or a loved one, including clinical assistance, treatment, and rehabilitation. Experiences that a person lives with when interacting with the healthcare system they have in place. Our case study, from which I'm going to share a few slides on results, it was a study, a multi-method study, which aimed to unravel the gaps in different therapeutic trajectories from the voice of patients, of adult patients with breast and lung cancer in Chile, according to their socioeconomic status and type of health insurance, both public or private, generally. This was funded by the pharmaceutical chamber in Chile, and it was coming from the support of different private companies that built a pot to produce this study based in our research team. We used a convergent multi-methods study, which had two components, one quantitative and one qualitative, that went through simultaneously. We collected data on the quantitative component based on a structured questionnaire that was created particularly for this study, as there was none similar available in the literature at that point. And then we produced results that were then connected and integrated with the qualitative component, which, as you can see here, was on that numbers for both breast and lung cancer. And then we went through a final stage of integration of results and interpretation of findings. Now I'm going to present to you just a few ideas on each, both breast and lung cancer, given time. So starting with patients with breast cancer, their patient journeys or therapeutic trajectories based on their own experiences as supported by the qualitative component of this study. We found generally differences between the private and the public system. And there were not necessarily differences in first symptoms and consultation processes at the beginning, but then, as you can see by this figure, more difficulties, as you can see by the number of symbols that the public system journey is showing, a number of limitations given high out-of-pocket payment, risk in delays, effective delays, which is the red flag, and bottlenecks. So generally, you could say that the private system seems to be able to respond quicker to breast cancer patients, but there are also involved high out-of-pocket payment, both in private and public. The public seems to be longer, and that's how it's experienced by patients. And it also has several bottlenecks that the private doesn't seem to have. In both cases, patients reported alternative and complementary medicine with out-of-pocket payment whenever they felt the healthcare system was unable to produce results and improvements to their particular health needs. There were a number of unsolved healthcare needs, as you can see from this list, in general, which is in the downside of the image, but also in particular stages like treatment and follow-up, as you can read from this figure. In terms of the quantitative, we've had a lot of information. I'm just going to show you a few things. In relation to breast cancer, in terms of first consultation, diagnosis, and start of treatment at those different stages of the patient journey, in general, 1 in every 5 people reported some delay, as reported by this orange color as yes, they reported yes, a delay. It stayed fairly consistent over time through the pathway. In terms of self-reported delay of patients with breast cancer in the first consultation, diagnosis, and start of treatment, similar to the previous one, we produced a measurement of gaps between public and private systems. So for the first consultation, patients from the public system reported 2.2 times more delay in the first consultation than the private. For the diagnosis, patients from the public reported 1.4 times more delay than those from the private, and for treatment initiation, patients from the public reported 2 times more delay than the private. Moving on to lung cancer, findings are in general somewhat similar, yet lung cancer was much more complex in terms of both patient journey and also delays. So here we see that there are different ways of entering the healthcare system. It could be a lung symptom. It could be a finding in an exam, like something weird in the thorax radiography or scan or something like that. And also could be the third one based on symptoms from other systems, like gastrointestinal, for example. Right? So they would come through different symptoms and reasons. And they would not have such clear difference between public and private as breast cancer, because they were perceived several limitations across types of healthcare system here. So you can see here that it's generally costly, with high out-of-pocket, with risk of delays, with bottlenecks for the whole process, and with the need of alternative and complementary medicines as reported by patients. Also, the worry of palliative care, because many of these patients get into the healthcare with a diagnosis very, very, very late. So they come with very severe stages, and therefore there's not much more to provide from the healthcare perspective. In terms of lung cancer unsolved needs, we can see again general ones, some of them very similar to breast and other cancers that we've had studied with. Thank you, Faye. Note at the time, but also some specific ones related to other elements around diagnosis, treatment, and follow-up. So this was a bit more severe than breast cancer in terms of delay. It was 1 in every 3 on average patients reported delay. It was 1 in every 4. I said 1 in every 5. Sorry, 1 in every 4 in breast cancer. Here is roughly 1 in every 3. Right? And in terms of differences between the private and the public, in the first consultation, patients from the public reported 2.3 times more delay compared to the private. For diagnosis, 1.7 times more delay compared to the private. And this is a heavy one. For start of treatment, patients from the public system reported 5 times more delay than the private counterparts. From this study and others, the report is an open, publicly available report in Spanish. Unfortunately, I apologize for that. We created a number of integrated findings with a list of recommendations for different level perspectives for patients, healthcare teams, health authorities, civil organizations, general community society, and so on. And just to finish with, so the study's findings returned to organized patients and study participants. We presented them together to the Ministry of Health with the civil organizations. We presented it to the Ministry of Health as a research collaboration between them and the academia. And they are now, through this research and others, advocating to be recognized in health coverage decision-making in Chile. And the study served as a unique evidence to speak in their own voice. With this, I'll finish. Thank you very much for the opportunity to share our research study with you, and I hope you've enjoyed it. Thank you very much. Back to you, Faye.
Thank you so much, Baltika. That was so interesting, and also quite stark contrasts there between public and private, which was really interesting to see. I know here at Teesside University, involving patients and public, that's one of our pillars of research. So it's great to see that you're also doing similar things, and that we can share those findings going forward. So thank you. So now I'm going to introduce our two expert panelists. They are Professor Paul Chesterton and Professor Bruno Natero. So I'll invite Paul to the floor first. So Paul is my good colleague here at Teesside University. He's a Professor of Learning and Teaching within the School of Health and Life Sciences here at Teesside. He's also a National Teaching Fellow, a qualified physiotherapist with experience in the Premier League, and he is a trustee for the Chartered Society of Physiotherapists Charitable Trust, and he used to serve on the board for the North East Musculoskeletal Society. So Paul, can I welcome you to the floor? If you'd like to make a commentary on the presentations, that'd be lovely. Thank you.
Thank you, Faye. Yeah, good morning, good afternoon to everyone. I really enjoyed those presentations, and actually it's really difficult to distill all that information. I've been making some reflections on the three presentations as I've gone, and I'll share those with you now. So yeah, as Faye mentioned, I'm a Professor of Learning and Teaching here at Teesside University. But my kind of old stomping ground career was as a physiotherapist, and actually there's a lot of overlap in the work I do in L&T, where we're very student-centered and we really pick up on the student voice, and the students are integral to everything we do at Teesside University, and we see our students as our partners. So we don't pull them along on the journey, we walk together. And I think that's had real resonated with me with the presentations from our three speakers of John, Manuel and Baltika. And I think what was really interesting is, for me, the crossover between a lot of what we do within a university setting and how we try and replicate that, and vice versa in healthcare. I think some of the reflections I was thinking about as I was listening to our speakers is about, well, what is this individual care, and about kindness and respect. And I think a lot of those values, they mean something different to everybody. And I suppose that uniqueness, that we all are unique, is central to us all as human beings. And I suppose for me, that is the core of what kind of patient-centered care is all about. Because we've all likely experienced healthcare, whether it's ourselves or our close family members, and we look at care and quality of care likely through a different lens. And it was really interesting, some of the points that John made about how there's not a one-size-fits-all approach, and that really kind of resonated with me in some of the work we're doing at Teesside, and that actually that everything we do impacts every aspect of our patients' lives in terms of the conditions they have. And a lot of the diseases which have been mentioned in our webinar, but obviously the hundreds of others that haven't been mentioned, can actually become the focal point of patients' lives. And I think in some instances, it actually becomes a focal point of their existence. So that's kind of the importance of, the level of what we're talking about, and, how patients cope, deal with, and empower themselves with the conditions. I don't think we can play that down. And I really kind of took that from kind of John's presentation about this patient-centered model of care. And it was really, really interesting and pleasing, obviously, to see about the stakeholder engagement throughout, and embedding really what is partnership, thinking about this collaborative process between us and our patients. And these principles, again, I refer back to what we do at the university with our students about informing, consulting, involving, partnering, but ultimately giving the control to our students. And I think a lot of those themes were really cross-referenced across all three of the presentations. obviously, I'm not going to go into the kind of each medical diagnosis which is discussed in each presentation, but you know, as John was discussing the long-term presentations and the ongoing process, again, what struck me was he was talking about change behavior and about how we have to potentially change patients' diet, how, you know, how we change their smoking habits, for example. And of course, that is purely reliant upon patient-centered care and our relationships with the patients, and then really how we develop and build our trust. And I don't think that should be underestimated at all. And you know, the patient-centered care transcends us all, and it transcends beyond national, kind of international and national boundaries. And again, from what Manuel was saying about the 9 million patients in Chile with morbidity problems compared to a capacity within the system of 4 million. Again, from a UK, you start to reflect how we understand over here that we need to do things differently, and that's and learning from others, you know, is clearly key and central to that. Having an integrated approach to really decrease duplication of care to increase efficiency is something that I think we've been banging the drum about in the UK for an awful long time. I qualified as a physio in 2006, and we were having these conversations back then. So a joined up approach, which of course will, you know, it's great to see decreased costs and other metrics, but it's also of course reasonable to surmise that this has a more patient focused approach and would likely improve patient satisfaction throughout their care pathway. And it got me thinking about my days, taking me back to my days as a physio, as I mentioned, and I worked in primary care as a musculoskeletal physiotherapist. And listening to Manuel, it really reminded me about how when patients came to see me, if they had a multi-site problem, i.e. they might have a knee condition and a shoulder condition, they needed 2 referrals for that. It wasn't within my power within primary care to treat both conditions at the same time. And this was mainly due to really a payment-based system that we had. So it was really interesting to kind of hear about how that model and the high risk and the low risk medium and the differences between. And I think what was even more exciting to hear about was this kind of secondary prevention model. And I don't think you can get any more patient-centered than focusing on prevention of disease. So, you know, integrating patient-centered care at the forefront of these models is, I think, a challenge for us all, and we can learn so much from each other. And I think what was really pertinent for me from what Baltica was saying about listening to patients' voice, and she made a really key point for me, which I really kind of resonated again, which was about patient participation is valued and desired in healthcare. And that should be authentic. You know, we want to develop inclusivity and accessibility for our patients. And in essence, for me, that's what puts the care in healthcare. You know, that's generally why a lot of us on this call or watching the webinar who work in healthcare chose a career in the first place. It's kind of what gets us up in the morning, is about helping and supporting our patients on their individual journeys. And again, Baltica was making some really pertinent points, some really seminal points around empowerment and the patient experience. And I think that's all really powerful. And again, talking as a patient myself and a father who has also had his children through a healthcare system, I think that's so integral to absolutely everything we do. So there's lessons for us that are here over the UK to learn and to share with. So, I mean, in essence, to kind of summarize, again, thank you to all the speakers for sharing that information. It was really eye-opening, and I really enjoyed it. But for me, it doesn't matter whether we're in Chile, whether we're in the UK, whether we're any other nation that we share this wonderful globe with. The seminal points raised today, I think, are worthy of consideration of us all in our healthcare environments, whatever there may be. And at the end of the day, the patient should be front and center of the model. And if we continue to do that, we'll make strides towards more patient-centered care. Thank you, Faye.
Thank you so much, Paul. That was a wonderful summary. And it just really drew together, like you say, the parallels between academia as well and healthcare. So thank you. And just to finish today with our last expert panelist, I'd like to introduce Bruno Natero. Bruno's an associate professor at PUC. He's also a surgeon, a faculty member of the School of Medicine, and the head of the medical oncology program at excuse me, Bruno, if I say this incorrectly, Pontificia Universidad Católica de Chile, and the president of Chile Without Cancer Foundation. So a huge welcome to Bruno. I'd like to invite you to the floor. Ooh.
I'm here, but you have to turn on my video.
Yes.
You can see me? Yeah.
We can't. We can see you. Yes, perfect.
Okay. Thank you very much for the invitation. I am from the Pontificia Universidad Católica de Chile, as you said. And I want to thank Manuel and Baltica for this invitation, and to the Universidad del Desarrollo for this opportunity to talk about something that is very, very relevant. And I want to rescue from the presentation of Manuel. We really need to generate a new model to approach to cancer care. And this model must be centered in the patient needs, because at least here in Chile, we are far away from there. And the second point that is very relevant from the Baltica presentation is that we must consider patient experience to develop this new model. So I would like to share the Chilean experience in the last decade to approach to cancer care. And we have been living a very interesting experience that started from the civil society that discovered the inequity in front of cancer care in the country. And we have been pushing from the university, from the scientific societies, from foundations and patient advocacy groups. And we have been, as in the rest of the world, pushing to do not accept the inequity that we have in the system now. So I'm a medical oncologist, and I'm 51, and I decided to dedicate my life to cancer care because it was very impressive for me when I was studying in the medical faculty, the really huge differences in opportunities for cancer patients in my country. So Chile, we are a developed country, but it's very unfair, the opportunities that we have to be exposed to risk factors, to be diagnosed, to receive treatments, and then to incorporate into the society back. And I'm very glad to be in front of many students from the UK and from Chile. And what I would like to discuss in the following few minutes are many opportunities to develop together research projects that could impact for the good of our patients in the UK and here in Chile. So the focus must be in prevention, early diagnosis, cost effectivity, equity, and again, to develop a new model to approach cancer care. As Baltica showed in her presentation, here in Chile, cancer is the first cause of death. We are 20 million people in the country, and we have 60,000 new cases of cancer every year, and 30,000 are going to die, so 50%. And this is not the same in any other developed country. For example, in the United States, and probably in the UK is really close to that. Near 1/3 of patients are going to die in the first year, but in our country is 50%. And the major reason for that is that 20% of the population have a private insurance or a private healthcare system with really good opportunities. And 80% of the population in the country, they depend on the public system. Now, the public system has very interesting approaches because they are very interested to prevent cancer. And this is not the same from the private side, but the waiting lines and the kind of treatments that our patients in the public side can receive are very different compared with the private side. So, for example, a patient diagnosed, a patient with digestive symptoms, for example, abdominal pain, or I don't know, if they lost weight and we are suspicious for a gastric cancer or a colorectal cancer, they could be waiting for 6 or 8 months for the colonoscopy or the upper endoscopy. And the system is going to recognize the patient that is waiting for a treatment when the patient was discussed in a special committee, probably after many, many months before the diagnosis. So the country do not know how many months this person was waiting for being diagnosed. So in the last 10 years, exactly in 2018, so 5 years ago, the Minister of Health that we had, he invited the civil society, and I had the opportunity to chair this group, to contribute to the Ministry of Health to develop our first national cancer plan. And 200 people from universities and again civil society, we worked together with the Ministry of Health to develop in 6 months our first national cancer plan, with the main objective to reduce the inequity in 10 years. So this is the National Cancer Plan 2018-2028. And this was a very interesting experience because the Minister of Health, he agreed to present that we had at this time in the country 17 irradiation machines, accelerators, and we needed at this moment 50. So he declared the difficulties that we had in infrastructure. And then we said we are 150 medical oncologists and we should be 400. And before that, it was very hard for people from the civil society to hear the Ministry of Health recognizing that we had troubles. So in 2020, in the country, we had the approval of the National Cancer Law. So this National Cancer Law was enacted, and we are one of the few countries with a National Cancer Law. It means that we can receive funding from the government to reduce the inequity directly from the government. And then we have a National Cancer Commission integrated from people from the civil society, and we must audit what the Minister of Health is doing in terms of cancer care. But what we really need in the country is information for policymakers, because they don't know, the Ministry of Health and people working in the Ministry of Health, they don't know about how long people is waiting for receiving the treatment. So it's very interesting. Last year, the Ministry of Science and Technology, they opened a call for developing a $6 million project for 5 years to develop a cancer research center in order to impact public policies. We, with Manuel and with Baltica, we are part of this group. I'm the director, and we are 90 researchers from really different perspectives. So this is a really interdisciplinary group, integrated by physicians, lawyers, professors, nurses, kinesiologists, engineers, and people from different worlds, and all we are together to recognize or to try to recognize and to identify what our patients need. And we are 8 universities and the National Cancer Center, the public National Cancer Center, and we have 5 years to develop research oriented to impact public policies. So what we are going to try to do is to develop the inequity map of the country. We want to evaluate how much each risk factor impact in our cancers. We want to identify and to measure how long does the diagnosis take, and how this is different in the center part of the country, in Santiago, the capital city, compared with patients from the northern part or the southern part of the country. We want to evaluate difference between older or young people, males and females, rich or poor people, in order to try to build a new model to approach the cancer care in the country with a lower inequity. We want to develop research, translational research, to evaluate the biological markers that we have, for example, abroad, how much they impact in Chile. And we want to develop new models to evaluate cost effectivity. So again, we have many research projects. I would love to invite you to contact Manuel or Baltica or myself in order to develop projects to improve the opportunity of our patients. So thank you very much.
Thank you so much, Bruno. That was so insightful. And actually, I think there's a lot of overlap between the research you're doing and the research that's occurring with John's team at the University of Teesside. So there's probably definitely room for scope for collaboration and discussing that after this webinar. I just wondered, with regards to the aim to reduce inequalities in cancer in Chile, you said it ran from 2019 to 2028. So you're roughly halfway through, and I just wondered how kind of are you on target to achieve what you're aiming to achieve by that time?
So the focus of the research project is to reduce the diagnostic time. So the major reason for death in my country, or the major risk factors, are not just to talk, for example, about obesity, alcohol exposition, or tobacco. So the main reason is the opportunity in the country. So we have 70 deaths every day because of cancer in Chile. We have 3 deaths every hour. And one of these deaths is because the person was in the waiting line or without the right treatment. So the main focus that we have is to try to impact in the prevention and early diagnosis, because there we have the major opportunity. So of course we have to work in prevention and to reduce the risk factors, but this is going to take a very long time. And now we have an emergency. So the major targets are to impact public policies to reduce this inequity.
Okay, thank you so much. I will look forward to keeping abreast of that and watching what you do. It sounds really interesting, so thank you for sharing. So now we're going to open up for any questions, and I wondered if any of the other speakers had any questions for each other following that presentation. In fact, you can all show your faces on the video if you would like. Good. I did have one question for you, John. And it was really interesting because when we talk about chronic disease, we obviously we know health literacy is a huge problem. In fact, they call it one of the newest vital signs. Yet you said people with chronic diseases are quite the opposite. They're far more educated and informed on their own conditions. So I wondered how that affected health inequalities within the UK. With regards to, I don't know if you've rolled this out universally yet, or if you've have any projections, but obviously we know chronic diseases disproportionately affect people from lower socioeconomic statuses. So I just wondered if you had any information on that, or if you've had a look into that.
No, I think it's a really good question. I really welcome, I think it was colleague Professor Netero who was talking about mapping social inequality. There are fairly broad maps of that within the UK, and we know that in the Northeast there's not only some of the highest prevalences of long-term conditions such as cardiovascular diseases and type 2 diabetes mellitus in the UK, but also in Western Europe. But I think we need a better regional map. And we need to understand some of the factors that contribute to these high prevalence rates. I think if we understand conditions better, then we can look to try to prevent them, not just treat, but prevent. But in answer to your question, no, I don't have a good understanding of the factors that contribute to health literacy and how that then informs the prevalence of these conditions. But it's a really important question. And I think there's work to be done there. Thank you.
Thank you. Baltika, this is your area. Oh, Emmanuel?
Manuel can go first. Go on, Manuel.
No, go. Have a
Very
different question.
briefly. It's live, isn't it? Very generally, I was thinking as I was listening to John and to your question, Faye, that I'm at this moment preparing a keynote speech for the 4th Global School on Health of Migrants and Refugees for WHO headquarters. And they asked me to talk about health literacy for migrants and refugees globally. And I've been reading quite a bit about that. And what I try to do, and that would be part of my reflection to the group and to who's listening, is that it's quite a complex thing because it seems to be something behavior related that you can see, but yet factors and triggers within are rather complex. And you've got the supplier side, which is the healthcare system and its capacities and limitations. You also have the demand side, which is the community and their own cultures, beliefs, practices that are interacting constantly with the supplier, the healthcare system. So we've got those two components, but you also have two more, which is the interaction between them and what happens there at point of delivery, which can change the game completely, positively or negatively, depending on human relations at that point. And then there is the broader context, the historical, geographical climate, socioeconomic context, policy context within which all these three elements are happening. And I tend to think that literature, especially clinical literature and health systems research literature, tends to think up to the top three, the healthcare, the communities, and the interaction, but they're less developed or researched around the general context, which provide historical, pervasive, structural inequalities and power relations that are unbalanced historically and are determining and influencing what is happening within the healthcare system with their communities. So I think we need to reflect a lot about health literacy and what it really means and where it truly comes from, if we really want to use it as a buffer or as a counter mechanism, and also a counter narrative to what we think and see and talk about when we think about patients. That's it. Thank you.
Mute.
You're muted.
Manuel, go for it.
Yeah, no, it's a different question to our colleagues in the UK. John, very nice to meet you finally. When we visited Teesside, we didn't have the opportunity to meet each other. And
Nice to meet you.
When I was presenting, I said that one of the main challenges we've got is to implement secondary prevention. Bruno also emphasized on that. And but we have this limitation in the system that you highlighted again, Paul, in your comment. We only have limited capacity. So we are trying to move to a different model of care. We're going to put more effort in the high-risk patient populations. So, but trying to mix these two perspectives, putting the effort in high-risk population, but also having these more universal secondary prevention programs. I would like to hear from you how you are thinking about this sort of screening programs that you've been working in Teesside. Is you are thinking more in a broader universal perspective, or more targeted for a high-risk population? How you are thinking that these new techniques or new tools for secondary prevention are fitting in the current NHS model? I would like to learn from your thoughts at this current stage.
Thank you, Manuel. That's a great question. I think there's a number of different strategies. They don't compete, but they are they can all go together, and I think it depends on the individual and their needs. So an individual who is my age, in his 40s, may start to experience lower urinary tract symptoms, and they need access to a test. And we know that there are lots of barriers to seeking health interventions, to going to see a clinician about symptoms, that urinary symptoms, a bit like fecal symptoms, and other sort of sexual symptoms, they're still taboo, certainly in the UK. So providing an individual access to a test and then providing some additional information about what the outcome of that test means, I think that's important. So I think one of the ways in which a patient can access their health is a test that they can purchase through a pharmacy or maybe online through an organization like Amazon. But we know from consulting many clinicians that they need access to tests that they can use that are accurate, inexpensive, non-technical, rapid. And so, yes, we need tools for the point of care sector, including the care home sector, where some of the tools that are available in primary care and secondary care just simply aren't otherwise available. So residential care homes and things. So that's quite a complex answer, and I haven't finished, but in the interest of time, I will. I think there's a number of different care settings and user scenarios. And actually, I think you need products to be available at all of them, because frankly, there's a need that has been expressed by patients, by carers, by healthcare practitioners to make these tests available at them all.
Thank you. Thank you. And I'm also very aware of the time. So I'm just going to finish by saying thank you ever so much, everybody, for participating in this webinar. Obviously, we know chronic diseases affect roughly 1 in 3 adults worldwide. So it's such a huge area, potentiated by aging population, polypharmacy, multimorbidity, and it increases that health inequality gap like we've discussed. So it's so important to just come to webinars like this to share what we're doing, and to remember why we're doing it as well, I think. So thank you everybody so much for coming. Thank you as well to UDD TV for live streaming this. And also for anyone who wants to watch this webinar back or send it to a colleague, there is a link that will be available that we will distribute as well amongst our institutions. So thank you everybody. Thank you ever so much for attending, and it's been a pleasure. Thank you.